Good afternoon, guys. Thanks for joining the First Name Basis podcast. This is a podcast that I, the CEO and founder of TribalScale, and many other members of our tribe get together, talk with industry leaders about actually what they're doing in their day-to-day. And we get really deep and technical about tactical things that we're doing. And we've moved our podcast to be a remote series because of this COVID pandemic. And so today I'm really, really happy that I have Anna Foat, who's the Global Director of Innovation for Sunlife. And we have Dr. Daniel Pepe, who also works at the London Lambeth, am I saying that right? Medical clinic.
You got it.
All right, perfect. Welcome, guys. We're live right now on YouTube, and the First Name Basis podcast also gets published on Spotify, iTunes, on Facebook, LinkedIn. It goes on all the social channels, so people can go find it later on also. But today we are going to be discussing this global pandemic we're in, and we are not all going to be talking only about the effects of the global pandemic, but we're really going to talk about a topic that I think is affecting everybody right now, our healthcare system, and how technology needs to impact this healthcare system, or the innovation that you guys have seen been happening in the healthcare system to help us better deal with the situation we're in. And so I wanted to frame the conversation first just by having you guys introduce yourself, and then we'll talk a little bit about what was happening pre-pandemic, what's happening during this pandemic, and what you feel life will look like post-pandemic. And there's a bunch of challenges in there. And so why don't I kick it off for you to Dr. Daniel Pepe? Why don't you tell us a little bit about yourself?
Oh, thanks. Can you hear me? I'm a family doc here in London, Ontario, and I share practice with my wife. Before the pandemic hit, I was a family doc. Since the pandemic's hit, I'm the Southwest Digital Lead for the pandemic in our region here. So that's a little bit about me. We do a little bit of different stuff in our practice, and we see people from birth till the end of their life. So that's me in a nutshell.
Cool. Anna, over to you.
You mentioned my day job, but my side hustle is patient advocacy. I've been doing it for quite some time. And about a year ago, I met Dan through the work that I did in the Ontario Health Team application for London, Ontario. Okay. So it's just been a great partnership that's evolved and really been the fuel for a lot of the work that we're doing.
And then you got another job with your family, and then you got another job dealing with me bothering you all the time, which is
I have a couple jobs. It's okay. I'm a woman. I can multitask. We were born for this.
I love it. I love it. I love it. So why don't we start off a little bit about the pre-pandemic and some of the work that brought you guys together and what it started to look like, and you walk me through like how did that whole engagement, how did you two get to know each other, how did you two meet?
Yeah, and do you want to start and I can follow up?
Yeah, sure. So when I first met Dan, I said to him, you're this young, cool doctor. Why are you wanting to get involved in this OHT stuff? And he said to me, I'll never forget, he said, for the first time in probably 40 years, there's a fundamental ability for us to create the healthcare system that we want to have. Mm-hmm. And as a young doctor, I got 30, 40 years in my career. So I'm right. That I myself want to practice in. And I just thought, man, like this guy's fantastic. And so, and like all patient focused, all very kind of, if you do right by the patient, the rest will follow, which for me as like this design thinker, put the customer in the middle, knowing mm-hmm. how difficult it has been for the medical establishment, which is pretty paternalistic still, to kind of flip and see things through that different lens was mm-hmm. such a breath of fresh air that I just said, what do you want to know about digital? Like, I'll tell you anything. Over to you, Dan.
Love it.
Yeah, Anna's the digital encyclopedia. Everything I've learned from her, from texting to getting links flipped to, just chatting on the phone and saying, what do you think about this problem? This is what we're facing. What, from a design lens, how would you look at this problem and frame it differently? Because we don't think about that in terms of the healthcare system. We have a very monolithic, I train you, you train me, I'm the Jedi, you're the Padawan, you have to do it because I did it this way. There's no thinking outside the lanes and outside the boxes. And the last year has really been thinking, what if we flipped it differently? What if we looked at it from this perspective? What is the patient's perspective in this? How could we just tweak things? Not a lot, just bend the system, not break the system. And that's what the last year's really been. So it's been really cool learning that business side, the tech side, the design side, because we don't have it in healthcare and we need it. It's in every other sector and it's penetrated deeply. But in healthcare, we're still this like, you know, boring monolith.
That's so, I mean, it's always been very surprising to me when I walk into any medical office and you still see these files with like your last name color coded all over the place.
Yeah.
And it just looks like, you know, a photocopier had a big party in there. It's just paper all over the place flying. And we're living in a world that's so digitized, and it's, you know, it's definitely been, and it almost feels like you go back into like the 90s or the 80s when you walk into a medical
Honestly.
clinic, and you're hoping that the medical profession is actually leveraging all technology to make healthcare better for you. So why is that? Why has it been so far behind?
Yeah, it's interesting. I think part of it is just the paralysis of being so busy during the day and trying to look after people and coordinate things that you don't have time to innovate and sit down and have 3 hours to just think about how could we redesign this or how could we do it differently. Like people will make comments about our office that we just built a year ago. They're like, it looks like a passport office. And they're right, because the walls are plain, the workflow we've thought about.
You got to get some art like me behind.
Yeah, exactly.
I need more Tupac
art.
And Missy Elliott and
in my office I have it. I don't have it in the clinic rooms, but I think part of that is just the busyness, and people go, you know what, it's patient care first, and then you have the other side of it where people go, well, no, it's privacy and security, and email's not secure, and this could be hacked. But here we are. I go through medical school, and I have to learn how to use a fax. Like, it's crazy.
It's crazy for referrals. I mean, I went to a doctor, and they were like, yeah, Sheetal, we're gonna fax the other. I was like, what are you gonna do? We're going to fax and wait for a fax to come back for an appointment time. I'm like, can't you guys just look at each other's calendars and book me an appointment on the spot? Like, these are simple things that have been available for a very long time, and the medical profession still hasn't taken it on. It's very, very shocking. So what was one of the first projects that, you know, Anna, maybe you could talk a little bit. What was one of the first things that you came in with your digital mind and said, oh, wow, we got an uphill battle, but I think this is a low-hanging fruit opportunity we should like go after? And maybe it's a little bit of a leading question, but what kind of pushback did you get when you brought that up? Because I'm sure the first thing was like, get off my turf. What are you doing?
For sure. Like, the thing that's always so obvious to me is I have an enormous amount of respect for healthcare practitioners of all stripes. And I just think they have so much knowledge, and I can't think of a more collaborative profession. It's never one doctor, it's a team. Right. And then when you look at how those groups are collaborating with each other, they actually have no tools. And so they're doing all kinds of things to try to hack for the patient's benefit. And one of the first conversations I had with Dan was like, hey, so like secure collaboration was a thing 15 years ago everywhere else.
Right.
Like, we got to figure out a way to get you all to be able to have an easy way that's not 18 portals with 100 passwords that no one uses, because there are consumer grade tools, and this consumerization, I mean, I want you to have it. I want you to have all the information about me, because I don't want you, who spent 12 years in post-secondary, to spend an hour looking through a PDF document. I want you to spend all that time and education on helping me.
Of course.
But I can see what they're doing, and it's horrible. It's not ideal. And I think it's not ideal in good times. It's certainly, you see it breaking in bad times, where all of a sudden these people-based and not digital-based systems just start breaking down because the people aren't there. And it's a crisis. And so a lot of what Dan and I first worked on was, when we start thinking about patient centricity and accountability in medicine, how do we, as part of the Ontario Health Team work that we did, how do we start connecting the community to the hospital to primary care to their patients? So a lot of it was just secure collaboration. What's the tool that we need that's going to do that job? Very simple, but hard, because it's all brand new.
Right. So what happened? as you started going through the process, what happened? What
happened first was, who are you? Because I mean, I'm just a patient, right? So like, who is this girl? But you know me, Sheetal, I get that all the time. So the whole, who the hell is this girl? I'm like, yeah, I know. You'll get to know me. It's fine.
Right.
But then the second of it was like this again idea, and I
For,
think it's
just for our viewers, those of you who don't know Anna, you're going to get to know Anna really well during this podcast.
And then the second wave was just kind of like, okay, how are we thinking about the problem? Because that's where I kind of start from. And we got to think about it from an inclusive perspective, not from a control perspective. So I think just like at Sunlife, just like at any big organization, London Health Sciences and the hospital systems are no different.
Mm-hmm.
It's this, well, wait a minute, we have a way that we do this and we got to control it. We got to centrally control it because that's the only way this is going to work. And very quickly, Dan and I did a lot of brainstorming around the hospital needs control, but how do we give them control in a way that allows for people in the community to collaborate and to have it be frictionless, right? Because those enterprise systems of record tend not to be that scalable or frictionless when you start extending them beyond the four walls of, your raised floor.
Of course.
It's a shift on the focus too, right? From the process focus to the outcome focus. Like, what are we actually trying to achieve versus, well, this is how we always done it and here's the process. Because what you run into when you try and bring in new innovation, new collaboration, new ideas is, well, this has to go through this process and this has to go through this process and that has to go through that process before you get to the point where people go, okay, now we can use it and now we can start understanding it. It takes time to even get that momentum so you can get people testing a solution, let alone deciding on something and agreeing to it.
Well, I love what you said there. I think that's something that we talk a lot with our clients about. And, when you actually start to go to outcome-based decisions, then, hey, that outcome sounds really good. All right, if we all could buy into that, then what do we got to do to work backwards to make that happen? And so I'm glad you guys took that approach. So let's get into some more of the let's get into some more of the meat. What, like, as you started to integrate and started to get some of that buy-in, how did the flow go? Did that make it a lot smoother? Did a lot of the red tape come down, and what happened?
I think Dan, you should talk about some of the early work you did with the paramedics, because I think that just so set the table.
That's exactly where I was going to go with it. So what we did was we talked to some of the leadership across the LIN, which are local health integration networks for people who don't know what they are, and paramedics. So one thing that people think about paramedics, they think an ambulance, they call 911, they come pick me up, they take me to the hospital. There's a whole new branch of paramedics that are out there now. They're called community paramedics or community paramedicine. And the way I kind of describe them is they get to act as my eyes and ears. So if I can't go and do 6 house calls on a day because I've got 30 people in my office, you can deploy them remotely and they kind of act as your SWAT team. So they have experience, they've got the tech, they can do the vital signs, and it's trusted so that hey, they went to Sheetal's house, he's got a fever of 39.2, his blood pressure is X, he's really sick. Then what we did was we actually used a secure texting platform so that they could actually text us securely. And what happens is as they send messages back and forth, they can be like, hey, they don't look really good. Here's a picture, here's a video, here's a set of vital signs. And all of a sudden, now I can expand my capacity as a provider beyond my office. Because before, the old way is they call my office, they wait for my secretary, my secretary puts them on hold, or worse, they fax my office, I get a note, I have to read the note, file the note, blah, blah, blah. And there's like 18 steps. This way, I'm on my phone, I get a notification, hey, the paramedics are at so-and-so's house, they're doing really well. Can you give us some advice? Well, yeah, you need to do this and this and this. And if this happens, I want you to go back in a day. And if that's the case, then I want you to inform me because we need to escalate care or do something differently. So all of a sudden, we've taken that communication time that was maybe a day or two, and we shrunk it down to an hour or two. So the responsiveness went way, way up. And then the other side benefit that we figured out we could do is we could add patients into the conversation to give them a live view of what was happening with their care. So they knew when I was talking to the paramedic, when I was talking to their care coordinator, when I was talking to their specialist. So all of a sudden we created, to use a business analogy, it's like Slack. We created a channel, and it was Sheetal's channel and Sheetal's care, and then we had all your care providers in one room. So all of a sudden, something that seemed impossible became entirely possible because we adopted secure texting. But the
which
barrier,
is awesome. I mean, as a patient, even then, like, so much happens behind the scenes, and you're like, does this doctor even know what the heck they're talking about? At least if you see this whole communication, this doctor has actually been working on what my issue is for a while.
Exactly. And so we get less of the pinging of the office going, hey, what's happening, which I would do in my own care because I'm like, hey, no one's telling me. But if they can see with transparency what's happening, all of a sudden the appreciation for the providers goes up. I feel less burnt out and you feel better because you get a window into what's happening, which we don't currently have.
Right. That's amazing.
Yeah.
I love it. I love it. So coming into this pandemic, you started the building blocks. It's taken you some time, as we discussed earlier. It's taken you some time to get there, but now I think the political will and any of the roadblocks that you guys did have go out the window because it's pandemic mode, and you really need, God bless all you frontline workers, but you really need all hands on deck, and efficiency is at utmost important as numbers start to rise and the system is starting to get overwhelmed. So what are we doing now to make this to deal with the problem that we're currently in?
Yeah, so I think what we're doing differently is people are looking at a common problem. So to Anna's point and your point before, we have a common problem. Now we're reverse engineering to figure out how do we solve it? What are the critical things that we need to solve? So it's like, okay, we need hospital capacity because we know a lot of people end up on ventilators. We need to virtualize all the clinics, which are traditionally not virtual. Everything is kind of, paper-based and whatever.
Right.
And then the other thing is we need a way to securely collaborate outside of our offices. Because I mean, right now I'm sitting at home because we're going in every 10 days when we're on call to limit the risk of exposure and try and protect the healthcare workers as much as possible. So all of those walls and silos are falling catastrophically fast. But I think to your point, Sheetal, about the building blocks that set us up over the last year were the relationships, right?
Okay.
Of knowing that we had engaged with other people, that they trusted us, that we knew that what we were proposing or what we were talking about proposing was actually for the benefit of the group.
Sure.
And having one collective problem being COVID, that's probably the main benefit of COVID. It's been the great accelerator across all sectors, right? It's forced everyone to get their stuff together really, really, really fast and then troubleshoot and iterate and do all these things that we should have been doing for years, but we've done what probably would have taken a year and 3 weeks.
Yeah, I mean, one of our,
cool.
you're so right that you say that. One of our largest financial services clients said more innovations happened here in the past month and in the past 5 years that person's been in charge, because everything went out the window. You got to figure out and streamline processes. But one of the things we chatted about, discussing in this pre-call before, and it was talking a little bit about collaboration and being able to collaborate with everybody in this unit. You guys are talking about a lot of different roles here. And to be able to move fast when you have so many stakeholders it actually poses a huge challenge. And so how have you been solving for that as this pandemic has not only created demand, and collaboration is really key because you have so many roles?
In a pandemic, no individual is an expert. So, epidemiologists know about epidemiology, and infectious disease guys know about infectious disease, but not epidemiology. And tech people know about tech, and doctors know about doctoring.
Right.
So I think if it's a forcing function, right? It's like we all recognize the enormity of the problem. And I think very quickly, people who are not maybe prone to putting their ego down had to. It's like, listen, we individually, none of us have a way to figure this out. The only way we're going to figure this out is if we all come together and kind of say, I know about this thing over here. I respect what you know about in kind of your lane. Let's figure out how we come together. And we got to come together between public health, science, primary care, patients, the hospital systems, assessment centers, like physical, virtual, new models. And to Dan's point, I mean, I think by showing people, the government did some great things fast, and showing people in the community that, listen, there are now fewer rules. So let's just get together and figure this out.
So what have been some quick wins? What have you guys been able to do, like in crisis mode? I mean, to get something done in crisis mode speaks volume in itself, as people are like actually just going out to save lives right now. But hey, if you build some of the solutions you're talking about, that it'll actually bring more time to save more lives. So how have you guys been dealing with that, and and what are some of the things you've been able to do?
Yeah, I mean, I can talk specifically around what we've done in my own office in the clinic. What we've done overnight is basically taken care that was 99% in person, and we flipped it to virtual, right? So we've said, okay, all that stuff you need to come in for, don't worry, you stay home, we're going to solve it virtually. So that's either portal messages, that's secure broadcasts, that's texting with patients, that's video visits, phone calls, based on their level of kind of tech expertise. And we've matched that overnight. We basically said, this is a new way of doing business. We can't put our people at risk. And so we figured that out. One of the cool things, I think, is learning how to problem solve on the go. So
Right.
you adopt a solution, you go, okay, you know what, that worked really well. That's not working so well. We need to change it and flip it and tweak it. So that's been interesting on kind of an individual level. I think on an organizational level.
So just on that, just
yeah,
on that, Daniel, hold a second
dig.
thought, but just on
Yeah,
that, I want to dig because I'm sure there's going to be lots of other medical professionals, hopefully, who tune in
yeah,
or watch this later. What are some of the prescriptive tools that you found worked for you? What didn't
yeah.
work for you? Like, what did your stack look like? This is not something you built out of the box. You're
No,
taking off the shelf solutions and making your own solution happen here. So,
yeah.
what are some of the names that you have put together? What worked for you? What didn't work for you? I think it's super important.
Yeah, so the base stack that we're working off as an EMR electronic medical record is TELUS. So that's PS Suites. It's one of the major EMR vendors in Canada. On top of that, we layered on Health Myself, which is secure messaging in between patients and physicians, and then also a broadcast feature. So you collect all the email consents as you go along and build your practice. And then what the broadcast functionality allows you to do is say, hey, this is the new procedure for the office. This is who's coming in. This is who's not. You click send it, and then you send out 7,000 emails instantly, and you can
Wow.
monitor the engagement on that. So that's been huge because we can communicate to our practice en masse what's happening. Now, for patients who are at kind of higher risk, so let's say, it's not your healthy 30-year-old sitting at home, but maybe it's your 70-year-old dad who's got multiple medical conditions, that's where the secure collaboration piece comes in. So what we've been using and exploring here in London is Reacts. So it's a secure collaboration platform that lets you do kind of like Zoom multi-video chat. You can do one secure text message. You can also plug in peripherals if you have them, like a stethoscope, and you can listen to people remotely. That's a little
Wow.
bit more technical and a little bit higher, but it works for doing virtual house calls on patients where it's super high risk. So there's
Wow.
lots of cool stuff in terms of the stack, but the key functions are really, you need some asynchronous one-on-one, you need some group chat, you need some video functionality so you can lay eyes on somebody to say, hey, sick or not sick. And then the peripherals and the remote monitoring and all those things get folded in on top of it. But it's really in early days is trying to figure out what's the critical stuff, what's the non-critical stuff, and just dividing them into two piles and then going through each one and kind of solving individually.
Wow. Wow. Wow.
Yeah,
Wow. I'm learning a lot right now. That's super cool. That, I mean, that's going to be the future now, like in the
yeah,
post-COVID world that we want to talk about. But we'll park that and we'll come back to that after.
yeah.
You thought that you were going on before I really interrupt you.
What was the other thought? Oh, at a system level, it's looking at this COVID problem and saying, how do we help people? Because the big fear looking at Italy, looking at other places is, what if all the docs go down? How do we then give patients an access point? Because if I go down and you don't have access to me, where do you go? Well, you go
Right.
to an assessment center, you go to Emerge. What do we have critical shortages of? We have critical shortages of PPE. So if we send everyone to an assessment center or the hospital, we chew up our PPE for stuff that's maybe not the highest risk. And so that's where Anna and I kind of sat down and said, how can we use some digital tech thing to allow people to self-serve and then also connect them with somebody if they need to be connected in a virtual way to mitigate that supply chain risk? Because the big fear is that, okay, we tell people you can go to this place, but if they go to a certain place and they use up a lot of that critical PPE, then we kind of put ourselves in a difficult spot. So that was the next piece. That's where kind of input health
Wow.
comes in, and that kind of self-assessment piece.
So Anna, just on that, that's an awesome way to solve a problem. Like, I love the thinking, like, hey, how do we can't send people there, and let alone that your solution is going to make more efficiency without having to send non-critical people. But this is actually going to solve our PPE issue as well. What are some other things that you've been thinking about that either have been implemented or that you could talk about, or what do you see? Well, what else? Like, what's the next? What else is on your product roadmap that you feel needs to be done?
Well, I think being able to act as quickly as we did. So, I think Dan has an enormous amount of cred when people saw that all of these kind of woo-woo, newfangled tech solutions actually were working.
Right.
And it wasn't a tech person like you and I saying so. It was an actual clinician saying, no, I'm actually using them. And he's done an amazing job with patient stories to kind of hit the point home to remind people that their job is not piecework, right? The care of this patient is, and their overall health is the outcome. And oftentimes it's not due to a lack of empathy or care. People are siloed, so they don't really know, or it's really hard for them to follow up and find out. And so when we looked at the pandemic and we just said, how do we offload this capacity? People really in their mind thought that solution is the assessment center, and it is a solution. We need the assessment centers, but we need the assessment centers for really sick people, and then we need trained people there to make the assessment. Most people are like me. I don't know about you, but my kid turned my Nest thermostat way up the one day, and I was convinced all of us had COVID. I kept taking our temperatures, and I'm like, oh my God, I'm sweating. Why am I sweating? And I'm like, oh, the thermostat's at like 79 degrees. Okay, we're fine. But I think, you know, anyone who coughs, sneezes, anything in this time goes, oh my God, like, and then you read the news and you read about all the asymptomatic people. And so, you know, in this world where a whole bunch of really smart people got together to try to figure out technically and clinically how to solve this problem, I come to it from the layperson's perspective, where I'm like, everyone's freaking out. Give me a tool to give me comfort. Because I don't understand the extent to which you guys are all sacrificing and what's going on behind the scenes. I'm just worried because I coughed and I feel hot right now. So, and that's like 80% of people, and that's okay. There's nothing wrong with that, but we need to understand that human behavior and deal with the 80% digitally. So the 20% can be dealt with people like Dr. Dan, because we need Dr. Dan to be healthy when his patients need him.
Absolutely. And it's so true. I mean, everybody's going through this right now, where you're scared to cough, or scared to ask for a tissue somewhere. I suffer from seasonal allergies, so everybody thinks I'm like patient zero for COVID. You get scared right away. I mean, if I sneeze, I don't want to go see my parents, and you know, it's probably the right thing to do right now. But it's pretty different. But Anna, you talk a lot about the waterfall, and put it in tech terms, the waterfall methodologies that really exist in the healthcare profession. And you bring this agile approach that, hey, it's okay to fail, and it's okay to fail fast. And we're gonna figure out different tech stacks and how to make things work. And you know, Daniel just walked us through an amazing way his clinic is doing it. But how have you started in the middle of crisis, as you know, failing made it seem like not an option? How have you both actually like started to fail fast and start adopting more agile methodologies to the day-to-day?
I think I'll kind of start, and then I'll flip it over to Dan, because I think recognizing that there was a technically possible way, having the relationship with Dan where he and I could kind of spitball back and forth. We kind of didn't start from a stop, right? We already had a lot of momentum to say, what if we, like, it all kind of happened because my March break trip with my kids to Montreal didn't happen. So then I was just at home. So I seconded myself to COVID. Might as well do something useful with my time off.
Of course.
And it's like,
I don't see you ever sitting still anyway. I mean, you're going to be like, Anna reminds me of like A Living Color. You know, the Jamaican guy's like, hey man, you got 7 jobs. Anna felt like she had a break because she only had 5 jobs that day. Sorry, continue.
Well, this is it. We kind of had this moment of like, okay, could we spend a day or two? Could this thing work? So like, how would it work? And how would we take the public health messaging, and like, what would the hospital want to do? And how would we include primary care? And we just kind of sat down and rolled up our sleeves and got a whole bunch of people in a room to say, this is, I think, what we need to do. And at first it's like, whoa, this is very different. And in times of crisis, I think it's legitimate, especially in times of medical crisis, for clinicians that are scientists to go, just try this thing. We've never done it before, but it might work. So It was a huge leap of faith for people. And I think part of the traction was, how do we protect our own healthcare workers? How do we offload some of the stress? And so people understood the outcome at a high level. And I was so impressed that people, in a very quick way, kind of went, okay, there's something here. We're willing to engage. We're willing to participate. And then it was an enormous amount of work. And I'll flip it to Dan to talk through clinically, how does this actually work?
Right.
So everyone kind of agrees, but like, we don't do things in a frictionless process in healthcare generally. There's lots of calls, faxes, care coordinators, secretaries that kind of make the world go round. What if we took all that out and this just had to just work?
Yeah, of course. Of course. Dan.
Yeah. Anna, you're bang on. I mean, I think in turn, I always kind of reflect back and try and debrief myself about how we even got here, because it feels like it's been 6 months. It's literally been 3 weeks of almost like 20-hour days to get everything set up, but everyone came down to the same level. The hospital and public health and primary care and EMS, we all sat at the same table and said, what is the problem we're trying to solve? And I think what made it really tangible is we could look to other countries and say, look at how their healthcare system crashed and burned when they didn't do the right thing and they didn't get together right away. And so that combination of fear and a very tangible example became really motivating. And I think all we did was we agreed to a couple base principles, which is we can't have people go into the hospital for every little runny nose and sniffle. We have these assessments and we've got a whole bunch of docs who want to help, but some of those docs don't actually have access to things like PPE and things that will protect them. And so how could they contribute to that workload? And I think someone used this word the other day. They said, how can we load balance the workload of COVID across the system?
Yeah, of course.
Right? So in a tech term, I mean, load balancing makes perfect sense in this case, where you've got people in rural areas where their capacity is already very limited on a good day. And then you've got a whole bunch of urban docs in London, maybe who work at walk-in clinics who are now closed because they don't have PPE. Well, we can just take that one human resource that was in one geography and say, you know what, you're going to support this whole region. And that's how that regional approach kind of bubbled up. But it started in London with a bunch of people who were willing to take a really big risk on an idea. And that then bubbled up to the region to say, hey, could this be a regional approach that we could actually adopt? Because it almost makes more sense at scale than it does in a very narrow capacity. It makes more sense to say, why don't we all just be in this together? And that was really neat to actually see all the docs coming in. So we sent out an email, Sheetal, to the docs and said, hey, do you want to participate with us? Within like 24 hours, we had 200 docs, and there's 280 docs within London Middlesex. And so that level of engagement was basically unprecedented and never seen before. So again, it speaks to this climate that COVID's created of this desire to really collaborate.
Docs are loving it and they want it. And what about patients? Like my parents, I mean, the amount of tech, I feel like I actually live in India and I'm doing tech support for them half the time. The amount of tech support calls that we get is like, it's overwhelming. And how are patients handling this change and being able to adapt? Are you finding it like you don't want to let me leave it. I'm gonna let you answer and I'll follow up after.
I think there's this misnomer that if you're old, you can't use tech. I think honestly, in my own practice, I've seen people in their 70s, 80s, and 90s use tech better than people in their 40s and 50s. And I find it's that generation, for whatever reason, actually wants to pick up the phone and talk to me. But the really young patients and the kind of older generation will use tech. I think they're adapting, and they're adapting in a real way because there's a need, right? If they need to connect with you, they will figure it out. And then it's incumbent on us when we're designing a solution or thinking of adopting a solution to, again, go back to this design mindset and say, what does the user experience look like? Is it complicated? Is it easy? How many steps are we asking? Are we designing for ourselves and just putting them through the paces? Or are we actually designing for people? And so that's been, I think, the biggest challenge over time is this constant conversation of what is the workflow? What are we trying to accomplish? What is the outcome? And the really hard part, and this is probably the biggest challenge in COVID, is it changes on an hourly basis. So you design something, you map it out, you've got it on Lucidchart, you're like, hey, we've got something. And then 20 minutes later, you get a text going, and could you also add this other thing in? And it completely blows up your whole, so that's been the biggest challenge. But from like a patient tech adoption standpoint, I think there's a desire to do it in the way that we've designed workflow both in the office and then at the regional level, is to make sure that if you have a proxy, so let's say you're doing it on behalf of your mom or dad, you could do it. You could go in and fill in their information as long as you have their permission. And in that way, we kind of level set and give access to people, because tech can be, it can create a difference, but it can also be a great equalizer, where if we take the pressure off and allow a certain percentage to self-serve, those people who don't have a computer, don't have a phone, don't know how to use the internet, could either go to an assessment center and be seen in a timely fashion, or call public health and get through, which wasn't happening in the early days. So there's kind of a couple benefits there, but I don't know if that answers.
I think the silver lining in this pandemic also is you're super close with your family. So there's somebody in your family who's going to be able to help you out and walk you through it and teach you. I mean, my mom has never FaceTimed me in her life, and now all she does is FaceTime me whenever she wants to talk. The other day, she's telling me how cool it is to work with all her colleagues, and they're leveraging Microsoft Teams. And have I ever heard of it? I'm like, Mom, you really don't even know what I do for a living, but I love it. I love the fact you're having these conversations with me now. But we got a question that came through YouTube right now. So one of our YouTube viewers is asking, are there other medical systems and hospitals that are working on these digital transformations? And I think, what are you seeing out there? I mean, from your day job, your Sunlife perspective on like how digital transformations are happening out there, and then B, for the both of you, you're doing this for London, but what other awesome digital transformations are you seeing out there that are inspiring you guys to do more?
So I think they're happening everywhere. And I think the good news of the pandemic is the government has also reacted. One of the big barriers was just reimbursement. I mean, no one should work for free, and virtual care was always tricky. Privacy was a little tricky, billing was a little tricky, couldn't quite figure out how to create the right experience and create the right model for doctors. And overnight, the government said, okay, FaceTime them, however you can connect with them, do it.
Right.
Look after patients. So massive roadblock just got removed. And, there's lots of people really obsessed with digital health that are kind of cheering, saying, and let's not go back. Like now let's actually axe the facts. Let's get rid of some of these outdated systems, and let's not take a step back into the past. Let's move forward.
Sure.
And you see tons of people, at least my point of view is all of these amazing digital innovators in healthcare, like Input Health. Input Health's been around, I think, 7 years. They've been grinding this out. They didn't come up with this yesterday afternoon. There's so much thought and care in some of these solutions, but there's not been an obvious buyer. Like
right.
you'd think Canada's like one big HMO, so it should be super simple. Like when I worked at BlackBerry, that would Jim always say, like, it's one HMO, man. Sell to one entity and boom, you're done.
Yeah.
But the reality is that's not it. And there's not an obvious buyer. So it's really hard for these guys to actually have a market for some of the stuff that they're designing. My hope after all of this is some of those barricades get removed, because I actually think there's so much innovation willing to be taken up. It's just been, the system has not been very friendly to that uptake for a whole bunch of reasons.
Well, it gets tough, right? I always think when you're in an agile environment, and it's tough for us at TribalScale, like I don't like responding to RFPs because RFPs are written in a waterfall way. These are the requirements. Here's what you must do, blah, 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 blah. Here's what we've spent the last 3 years figuring out what needs to happen. And you're looking at it going, well, the solution may not make sense for today because you spent 2 years trying to get this RFP together to go out to the market, as opposed to saying, hey, let's figure out what's buy versus build and how can we put together a solution to solve a problem for today. And it's going to be very interesting to see after this post-COVID world how even the RFP system changes, because you're absolutely right. It's not just one entity that you sell to and it's going to be everywhere. It's every single region and every health network is going to have their own systems that they need, or own investments they've made that they need to now leverage to be able to do some of the cool stuff you guys are doing. So what was prescriptive, and correct me if I'm wrong, from my understanding, is what was prescriptive for Dr. Pepe's clinic may not be the right solution for someone else's because they're on a completely
100%.
different. Right?
No, it's 100%, and it's this really interesting balance between what is the standard of care and what are the things that we're trying to achieve for everybody. And there's a certain amount of standardization that you need in terms of open APIs and interoperability. And I think if anything comes out of this, it's that system interoperability, because people were building all these walled gardens saying, oh, to get that data out, it's X amount of dollars. But now those walls are falling because, like, if I can't get that data out, I can't make a decision. I can't help somebody. And so I'm hoping if there's one wall that falls, that's the wall that falls down, because interoperability is key.
You're speaking our language. Look at you. You're in a t-shirt. You're talking about interoperability. You're looking at outcome-based solutions.
I had a good teacher. I had a really, really good teacher, and I still do. This is all channeling my inner Foat. Like but it's so needed.
I love it. There's a quote.
It's so needed though, because we're killing ourselves, right? Like that's what we're trying to get at, is how do we stay nimble and agile? And the reason that we're seeing it week to week here is because the guidelines keep changing. So we need to keep iterating the solution. And so we're kind of dealing with like a moving RFP down here in London, but it's already scaled down to Windsor. It's going to scale up towards Hamilton. And so that notion that we can't scale and spread things quickly, in my mind, is really dead. Like
Right.
we've proven, I think we've laid down the precedent to say this is totally possible. And like I think the thing I said to Anna the other day was we've opened Pandora's box. Can't close it.
Yeah,
We
of
just have
course.
to figure out now how to manage that ecosystem.
Of course. Yeah, absolutely. Pandora's box is open. I mean, this is now going to become, well, wait a second. You were able to do a Zoom call with me or whatever.
Yeah.
It may be, so that you could, you've set a standard now that patients are going to be like, hey, why can't we do that more often?
Yeah.
I shouldn't have to go all the way in to come see you if it's something, if we're just going to do a quick checkup, and we could go from there. All right, we got another YouTube question. I love it. They're coming through. User is asking, we're all struggling to manage our health right now, physical, mental, emotional. What tools or activities would you recommend improving these things while in isolation?
Yeah, that's a tricky one. So there's a couple different ways that you can do it. And the way that I'm framing it for my own patients is you can self-serve. So there's stuff like Bounce Back. There's programs that the ministry have funded at a very high level so that everyone can go and access it. And then you've got to look at how you change your day-to-day routine. So if there's something that you can do to give yourself some physical activity, if you have a backyard, if you can run back and forth across your apartment, like these are the little things that we're telling our patients. And then you have to leverage things like Zoom and FaceTime so you can connect with people. Just because like I can't be 3 feet away from you doesn't mean that I can't call you up and be like, hey, what's happening? Because those mental health check-ins are really important. And this is interesting because it's actually refocusing, I think, everyone's perspective on their priorities, right? It's health, it's family, it's your well-being, it's kind of doing that internal growth. It's not all these deadlines and things that we had pre-COVID. So it's giving us a lot of time, I think, to reflect on what the priorities are. But I don't know, Anna, what would you recommend from your side? Patient's voice is always more important.
Well, it's hard, right? Like, I think, as you saw, I'm here trying to, do my job and do my side hustle and keep my kids not on screens 24/7. Apparently I'm also in training elementary school teacher, because the teachers are going through the same, right? Like my son's teacher sent me Google Slides, and I called her and I said, so my 6-year-old can't really read the slides. So what's he supposed to do? And she's like, well, you'll just work with him all day. And I was like, so I have a job. I can't, like, I don't have 6 hours to do this. And I'm not a teacher, and I'm also his mom. So it's not the same dynamic. So I think, honestly, I've been texting a lot of my friends just saying, there just comes to a point where you just have to let a lot of stuff go, like pick 2 or 3 things that are important and literally let everything else go. Like, I think we're at, what did I read the other day? We're now post toilet paper hoarding. We're now at hair dye hoarding.
Hoarding.
So,
I saw that,
the different cycles. So it's, now I think we're soon going to see people no longer making sourdough, because it's fun a couple times, but then it's like, it's a lot of work to make some breads. So, trying to find the new normal as this thing cycles through, and every week is another week of, being trapped inside. And you have to, I just keep thinking, because I work so closely with Dan and others, I am so lucky. I'm not locked inside. I'm grateful to have a roof over my head, and I'm grateful to be safe inside. So trying to remind myself of that.
Absolutely. I think, I sit on the board of Feed Ontario, which was previously known as the Ontario Association of Food Banks, and we see the shortages that are happening around the province right now, and how we're helping, do everything you can to help. But it takes a second. As much as I go crazy locked in my own house, I'm like, hey, wait a second, I got a roof over my head. I still got an amazing job, even that I get to work with some of the world's smartest people every day. I still get to eat, but now that my wife is home 4 or 5 meals a day, we're super fortunate. We got to do the smaller things that whatever we can to help out those less fortunate, because unemployment numbers just today in the US came out again, and it's unreal the amount of people that are going to be out of work and are going to need help. So absolutely take some self-reflection to know how fortunate you are, and what can you do to band together to come out of this as a community. I think is going to be super important. We can't leave those less fortunate than us behind. That's just not the way the fabric of our society, I firmly believe, around the world it works. We're just not, humans just aren't wired that way. We got to go help each other out. Here's another one. What would you say to those folks who are still failing to follow basic social distancing guidelines?
Can I swear?
I don't fucking mind.
It's like, seriously, stay the fuck home. Stay home. I would like to get back to the office. I really, truly would like to get back to my office and back to my regular routine, and soon. And so right now, every time I see people behaving irresponsibly, I think of all the doctors that are putting themselves, PSWs, hospital cleaning staff, grocery store workers, pharmacists, putting themselves in harm's way so that we can have the privilege of staying home. And so, you know, and I just think the consequences, we just keep delaying and delaying and delaying the return to normalcy. So if everyone just stayed the fuck home and listened to medical advice, we could all get back out to going to bars and having drinks. And I'd like to sit on a patio with you guys in the summer. Like, and I don't want to not be able to do that. I don't know
when summer's coming. It's just snowing out the window today. We're in April. I don't know what's going on.
It's constantly snowing.
Doctor, what do you say? What else?
They need to stay home, because the reason things are not as bad is that people are following the rules, and that the reason things are stable is that people are kind of playing by the rules and listening, and they're staying inside. Even going outside, even talking to somebody a couple feet closer than you normally would, even going over for that one visit could share the virus, because we don't know everything that we need to know about it to be able to provide you with all the exact situations where you can be safe. So you have to make the assumption that any cough or sneeze could be COVID. You have to make the assumption that if you go out and do something irresponsible, you put somebody else at risk. And it's not just yourself at risk. It's your grandma, it's my grandma, it's other people's family. Like, we don't know who we're actually putting at risk, and so you have to be careful.
It could be your friend. I've unfortunately seen more posts on social rather than not of young people. This is not just an old thing, of young people passing, and, you know, people really heartbroken over their wife or husband or friend, sister, brother. I'm going, this is not just something that's going to affect our parents, and it's pretty scary.
It's super scary.
You know, I look at it. I went for a walk, so I'm in the office today. I come into our office once a week. You know, I gotta check the mail, and I try to wipe stuff down, and just in case somebody else came by while I'm not here, even though they're not supposed to. And so we'll come by here once a week now, and to just get ourselves organized as TribalScale. But I usually go take a walk, and I went and took a walk outside today and get fresh air, because I feel like I never get to do that anymore even. And got some fresh air, and then went to just a Tim Hortons. And I gotta say, I'm really scared, because I feel like 90% of the restaurants, bars, small little shops, everything that I walk past, I'm honestly very fearful of how are they going to come back? Like, how could they come back from this? If rent is still due and salaries are, you know, have been taken away, all revenue has been taken away, and they obviously have to support themselves right now. You need some sort of capital to come back to this, and I'm really fearful for when this economy reopens, that we're gonna have to do even more to support, especially the small businesses in our communities, because it's just devastating. I mean, looking outside right now at the window here in downtown Toronto, I actually can't see one person, which is great because everyone's following the guidelines. But that's eerily scary on Thursday afternoon. When you look out on King Street, you just see people everywhere. Which brings me to a question, going back a little bit to healthcare, and going back that we have you two experts who are on the front lines. How do you see this economy reopening? How do you see some sort of life back to being a normal life happen again? Do you see staged approaches? What do you feel should happen? You guys both work really closely to this field. What do you feel the right rollout should be?
I don't know. I think that's a really tough question to answer, because we don't fully understand the extent of the disease and the spread and the impact that it's having. It's kind of happening slowly over time. Obviously, the stage approach makes sense, but I think you need data to inform that. because otherwise you're doing it blindly. You're saying, here's some gross aggregate numbers from regions, and you're just, making a best guess. But what could happen is you could reopen and you could see a spike. And so it's got to be done really carefully, really methodically. And I think we have to do everything we can to support people so that they can work in a virtual way as much as possible, that we can have that contactless business, right?
So Doc, here's a blunt
I
question.
just add,
How are
Sheetal,
we, sorry, go ahead, Anna, go ahead.
well, I was just going to say the picture that I saw this morning that to me kind of summed it up was from Ohio. So we used to drive a lot through northern Michigan, and in Lansing, they had this ridiculous protest yesterday with boats and, F-250s and people gridlocking.
Yeah, I saw that.
And preventing ambulances from going to the hospital. So you see that, but then you see this picture in Ohio with people, and I think it speaks to what you're talking about. They don't have income, and that's a desperate, desperate place to be. So they're pressed up against the glass, screaming at their governor, like an inch away from one another. And you think, I get it on one level. I get it. You're terrified, and you don't know, the future's uncertain, and that's scary. But you are literally creating the zombie apocalypse. Like, you're coughing on each other, you're spitting on each other, you're doing all the things that are going to make this go on longer than it needs to be.
Right. So one of the things I think to reopening is widespread testing. We're talking, and Doctor, you've been talking a lot about data, and Anna, you've been talking a lot about data, and we just don't have the data yet. How is Canada actually doing? You guys are there. You see the front lines. How are we actually doing on testing? I mean, I think I'm being pretty critical because I know a couple people who got tested and it took 7-8 days for a response. And I think that's ridiculous because any data you're showing me in the media at that point is a week and a half old, which is ridiculous when you're in a pandemic. But what do I know? So that's just my hypothesis. I'll be the first one to criticize, prove me wrong or right. What is reality?
I think it's getting better day by day. So we see the numbers coming into the assessment centers in terms of the number of people going in, the number of people getting tested. So the will to test is there. The centers to test are there. The amount of tests are increasing day by day. And I really think there were a couple critical supply chain issues in terms of reagents to complete testing. And so the desire to test is there because we know the right thing to do is to test people and to test widely and contact trace, because that's basically it, right? It's test, trace, and treat are the three things that we want to do. So I think that effort is there and that political will is there. I don't understand the inside of the machine, so I can't comment on that piece. But I think people know what the right thing to do is, and I think there's people sitting at those tables who are pressing and pressing and pressing for that, level of testing that we need. And I think it's coming. Obviously, it can't come fast enough. It should have come last Tuesday,
Sure.
But people are pushing on it, which I think is better than people not pushing on it and being happy with the status quo.
Well, is it safe to go get a test? Is it like, if I sneeze or whatever, I probably don't even want to go to get a test because if I don't have something, I might go there and get it.
Yeah, but that's the benefit of virtually triaging people. So when people will come through the input health, like Population Health Navigator, we'll see them, we'll virtually assess them, and then we get to stratify them. So if they're a healthcare worker and they're symptomatic, they get a test. If they're a healthcare worker who works at an institution, like a long-term care home or retirement home, they get a test. If you have diabetes or heart failure, some medical comorbidity, and you're symptomatic, you get a test. So that testing criteria is increasing. I just updated it on, I think, the 11th of April for here in London. So it's increasing and scaling day by day. If you're young and healthy and you sneeze and maybe it's COVID, what we're telling people is stay home for 14 days. But if it gets worse, if you get crushing chest pain, if you get confused, all that stuff, then you need to go right and get assessed.
Okay. Do you foresee, Anna, especially like put your day job in, do you foresee that it may be like a medical benefit coming soon where, hey, employers actually have test kits and we test and we do more widespread testing to come back to some sort of normal life?
Well, I don't know about that, but we've already announced that we'll fund through people's group benefits virtual care post-COVID. So, and that, I mean, you see it with doctors adopting it. You made the point about patients wanting it. So yeah, I mean, I think we have a huge role to play. And I think what's the supply chain has taught us is, as much as we've operated pre-COVID, like in these silos. And, I keep saying to insurance companies, we're asking for things like attending physician statements and doctor's notes. And you see in this time of crisis, doctors saying, no, like this is silly.
Hmm.
I've been saying it for a long time. We're all connected to one another. Our business is reliant on people like Dr. Pepe because we can't assess clinical risk. And so
Of
the
course.
same thing with supply chain. We thought, oh, it's easy. We'll just order them. Well, except we can't order them. And then they came with mold. And so we have to get, and you've seen Canadian innovators kind of coming up out of nowhere, like
Sure.
Jim Estel at Danby is making ventilators, and he's not waiting for government. He's not waiting for anyone. He's figured it out. And
Yeah.
I think more and more
And shout out
people
to
are
him.
stepping up.
Shout out to him. He was EY's Entrepreneur of the Year. I was fortunate enough to be a finalist this year, but he was EY's Entrepreneur of the Year. So shout out to him
Yeah, he's
for
cool.
stepping up and doing that.
So I hope that, I think government's been a lot more receptive to doing things in a different way. That's huge. I think innovators are kind of stepping up and doing stuff. And my kind of rallying cry is bring what you can. So like everyone has things that they can add that are useful,
Hmm.
but don't be an island. Like don't be a know-it-all. Don't, because first of all, no one knows. We're all amateurs.
Right.
But we need to work together. Like the partnership between Dan and I is so strong because I have an enormous amount of respect for what he knows. So he'll ask me
Absolutely.
questions about APIs, and I think that's kind of cool that, I can teach him about anything.
Interoperability,
Yeah,
APIs.
There's a lot to learn.
yeah.
There's a lot to learn.
I
That's how
love it.
you win, though. That's how you win. Is you have to be humble. You got to be the dumbest guy in the room. You got to figure out where the smart people are. You got to talk to them and say, what do you know that I don't know, and what do you have that we can share? Because
Right.
that's how you win. So if that's your rallying cry, Anna, my rallying cry is put the patient first, and everything else will follow. This is not about budgets. It's not about businesses. Not about how much you have and how much somebody else has. It's about doing the right thing for the patient that sits in front of you, and that's how we get through this. Like this is a human problem. It's not a tech problem. It's not a medicine problem. It's a human problem.
Absolutely. Well, very, very, very well said. We're coming up to the top of the hour here, and this has been very informative for myself, and I hope for a lot of the viewers. And I want to kick it off to you to start talking a little bit about a recap as to where you see us going post-COVID, and what are some key takeaways that the audience should come away with, whether it be their own journey within the healthcare system, or if you're working in the healthcare system, what are some mindset changes that they should start adopting?
I think, like, first and foremost, the idea that just because it's the way that it's always been done doesn't mean that it's the way we have to do it going forward. I
Mhm.
think there's a really real concern in medicine about not moving fast and breaking things because they're people. But you can't over rotate on, it's going to take us 17 years. The stat that always sticks with me is 17 years from the time a scientific paper is published to the time it becomes commonplace in most clinicians' practice. So like knowledge translation and breaking the way that people do things and axing the facts and all of those things, I think now people are being thrown into the deep end without a life preserver and realizing that in fact, these are useful and additive. We're not
Right.
taking things away from people. The other thing I think is I just have had an enormous amount of empathy working with Dan. So if you're not in the healthcare field, especially if you're a technologist that just assumes that everyone else kind of clicks buttons and everything's open and transparent, it's not. And so if we can help our frontline healthcare workers get information, it's as simple as, can I arm them with information in real time so that they can do the thing that they were trained to do? Can we make sure that pharmacists have my full medical report? They went to pharmaceutical school and I show up and they don't know anything about me. So, it's almost like you're cutting them off at the knees, all this knowledge that they have that they can't use because we're not making things transparent and accessible.
Very cool. Dr. Daniel Pepe, off to you.
Man. How do I follow Anna after that? You basically, I agree. I think with all those comments in terms of giving us information, giving us the data that we need to be able to make a timely decision, because I think everyone's care depends on it. And the more boxes we stick stuff in, the more roadblocks we throw up, it just ends up delaying care. And so I think we have to be really smart about how we design the system of the future, to think about putting the patient at the middle, giving them access to their information, because I think what I've seen in the last couple of weeks, it's not terrible to give people their whole record. they actually appreciate it. And if they're somewhere else where they can't get to you, they can actually share that directly with someone else, and that benefits them. So we have to look more about how can tech enable that, and how can they make it common practice. Like to your point,
Yeah.
Sheetal, at the top of the podcast, like files with names and labels on it. Those are days of the past. Once they're 10 years old and we don't have to keep them anymore, they should never be coming back. You should be able to go and access everything from the cloud all the time.
All the time, absolutely. I think you brought up a great point about like being able to control your own data. I mean, if you look at the devices we're wearing, I got the watch, I got the phone, and it's so cool that I'm tracking my sleep. I'm seeing that, okay, I know, take you sleep tracker, I don't sleep enough, but sure, you're tracking it and you're telling me that I'm not sleeping enough, but you have this amazing data. And it'd be so cool that, hey, when I do have a visit with a doctor, if I had access to that own data, so it doesn't matter where I am in the world or what's happening, it's like, here you go, you have, you have all my information. I guess that change is going to come. There's going to be way more of a willingness to do that. And you guys are taking the right steps to do that. Thank you so much for taking the time and joining me on the podcast today. Super informative. I hope that the viewers got to learn a lot about what's actually happening, what the challenges are, and why, and how change is coming to the healthcare network. I also think you guys had amazing points about what we need to do together and what everybody's role plays to come out of this pandemic together. Again, I'm hoping, and I'm going to put you guys on the spot, that we could have you back sooner rather than later to give us an update. And I'm sure as we start publishing, this First Name Basis podcast again is published on every social media channel. It's on Spotify, iTunes, LinkedIn, Facebook, Twitter, our homepage. We'll write blogs after it. This content is going to live for a while, but one thing I do want to do is hope that we can invite you guys back. And as more and more questions come in, maybe we just do like a follow-up and a recap based on all the questions that came in. So if you're watching, please do engage and send in your questions, because I hope you guys guarantee you guys will come back to do it.
Totally. Amen.
Awesome. I want to speak for everybody who's not working in the healthcare world, to really thank you, Anna, and you, Doctor, for doing what you're doing right now. You guys are really saving us right now, and being on the front line to helping us come back. So I thank you guys from the bottom of my heart for all the hard work you're doing to make this world a better place for all of us.
Thank you. I really appreciate it.
Well, thanks for the platform. And you're everywhere and everywhere. So you're spreading in the best possible way, like a virus, Sheetal. And I hope that maybe you can inspire other people to kind of do what they can do and collaborate with others.
Yeah, absolutely. If I can't be jumping on a plane and going everywhere all over the world, I'm going to try to spread through digital all over the world. So thanks again, guys. Thanks, guys, for joining us. Appreciate it. Thank you.